So good evening, everyone, and welcome to the National Blood Clot Alliance second annual July PEP Talk, Blood Clots and Compression. We're super excited to be here with everybody tonight. Before I introduce tonight's clinical guest, who is back by popular demand for a second year in a row, we do want to remind everyone we are not here tonight to give you medical advice. We are here for educational purposes only, so we request that you always consult with your own doctor, as every patient is unique. But we do hope to give you the tools and the education necessary to have that discussion with your clinician. So with that, we'd like to introduce and thank Dr. Wasan for joining us again this evening. We're delighted to have you back. And as many of you know, she is a clinical professor of medicine at the University of North Carolina Health in vascular medicine. She attended medical school at the University of Texas Health Science Center at San Antonio. She did her residency at the University of Oklahoma Health Sciences Center in internal medicine. She did her fellowship at the University of Oklahoma Health Sciences Center in the area of vascular medicine. And she also has a Master of Science, again, from the University of Oklahoma in epidemiology, which has a wonderful department. So we're very excited to have you here. Dr. Wasan is, as you know, a world expert in the use of compression, and she'll be sharing a lot of information with us tonight. So before we get into the meat of the matter, we do have our polling questions, and I'm going to turn it over to Todd so he can kick things off with those polling questions. Todd?
Well, thank you so much. I love kicking things off. I love the poll. This is really important, folks. I love it. We love it when you get involved and enter the data, because we do use this. So please answer these questions. They're very simple to click on yes or no. Have you ever been diagnosed with a blood clot? Yes or no? Did your doctor speak to you about compression at diagnosis? Yes, no, not applicable. Do you currently use compression? Yes, no, not applicable. And our fourth and final question, do you suffer from, and check all that apply, swelling in legs, pain in legs? Not applicable. If you could answer those, we're going to give the results real quick and then head into what I know is going to be an amazing presentation.
Yes.
We always have so many questions on compression. It's quite the topic in the support group. So let's see what these results are, and then we'll get on with it. All right. Have you ever been diagnosed with a blood clot? 84% yes, 16% no. So we have some folks that just want the education. Love that. Did your doctor speak to you about compression at diagnosis time? 38% said yes. 47% said no, 15% not applicable. Do you currently use compression? 63% of you saying yes, 29% no, 8% not applicable. Do you suffer from swelling in legs? 48%, pain in legs? 37%, and not applicable? 40%. Back to you, Leslie.
Great. Thanks, Todd. We're always dismayed at the lack of communication on topics for our patients. Yeah. And so hopefully we can start to improve upon those numbers and give clinicians the tools that they should be speaking to patients about as well. Okay, so we're going to kick it off again tonight. Dr. Wasan, so you're the expert in all things compression. And, you know, a lot of us on the webinar, we actually really struggle with compression and what to do vis-a-vis our healthcare providers. So can you actually just like walk us through what compression is and why it's important for people, et cetera, and then we can kind of go through the presentation with you.
Thank you, Leslie and panel, for having me. It's a pleasure to be back this year and provide some education and some updates regarding compression in patients who have a DVT. So I'm just going to do a short presentation and then we'll take your questions. Here we go. Okay. So I think the most important question to answer is, what is the goal of compression? Is it to prevent the post-thrombotic syndrome, which we'll define here in a minute, or is it to treat it, people who have symptoms that are given before? So post-thrombotic syndrome has been very well worked out now, but it essentially is a constellation of signs and symptoms, including pain in the leg, swelling, itching, heaviness, cramps in particular at night, tingling at the end of the day. You can develop varicose veins, redness that may look like an allergic reaction, skin darkening, and even venous ulcers. So these are the typical symptoms. And so it's really important, are we trying to prevent these symptoms and signs? You see some examples in the pictures there. Or are we trying to treat existing signs and symptoms? And I think the goals of a compression are really important to define, and it may be both. So these are kind of ugly pictures, and hopefully nobody's eating dinner, but these are what we think of with the post-thrombotic syndrome. You see these legs are very pigmented and diseased. Some have an ulcer, and they're very distressing, and some patients will present like this. But actually, the majority of people with DVT actually look like this. They have a little bit of subtle swelling at the leg. You can see in the middle panel, the right leg is slightly bigger than the left, or they may see just a few little dilated venules at the ankle. So the good news is that most people will have subtle signs, although the pain and suffering may be out of proportion to what we see in terms of how the leg looks.
What is it that causes the extreme cases of the other 5%? What's the commonality there?
So I'll go through the physiology here and answer that on the next slide. So it's a good question, Leslie. So how do you get differences in the presentation? Some of that's due to extent of the blood clot, and some of that is due to the findings on the vein. What happens is after a blood clot, the post-thrombotic syndrome is caused by one of two things, and sometimes both together. One is the residual obstruction where the clot turns to what I tell my patients is a scar tissue. So the analogy to use is there's narrowing in the road. So the road, things back up. The other thing that can happen is the valves that keep the blood moving, they can be damaged or destroyed by the clot. They're paper thin. And once you have a clot, the valve function is affected. So here we see it's a little bit complicated, but here we have the deep vein there on the right and a surface vein. And what happens is the blood essentially falls down to the ankle, and you get the pain, the swelling, and the heaviness. That's what we see going on in the left panel. The body doesn't like the swelling. The swelling is very inflammatory. It causes that redness that often is mistaken as an infection or cellulitis. And over time, the body's natural response is to produce those skin changes that, Leslie, you see are so damaging. Over time, that will lead to the scarring, that darkening, the pigmentation, and ultimately to an ulcer. Not in everybody, but in those 5%. And so the role of compression is one, to prevent the very first signs and symptoms, the swelling. And if we can prevent that, then we can prevent the inflammation and the skin changes that will follow, as well as help with the symptoms of post-thrombotic that I showed you on the last slide.
Mm-hmm. Dr. Wasan, you'd mentioned cramping up in that first slide, and you said especially at night. Why do we cramp up more in the evening?
Yeah, and this hasn't been well studied, but the general feeling is when you accumulate the fluid in the leg and in the tissues at night, and you go to bed, and that mobilizes overnight, and a lot of people will say that they have to go to the bathroom, 10 times during the evening. They think that there is the fluid goes against the skin membrane, and that precipitates the cramp. So it's the resorption of fluid overnight that they believe is what the precipitant of the cramp. They also think this is the reason people get restless legs, which also have been associated with the post-thrombotic syndrome. The best theory right now, it's not been well studied, is that mobilization of fluid overnight precipitates the cramp. So if you can prevent the fluid accumulation, many people have much improvement in their cramps overnight. So, some of these things like, cider vinegar or this or that really don't work for this. At least that's what I tell my patients.
Thank you.
All right. The landmark study called the SOX trial. And this was what we call placebo trial, where she randomized people to a placebo sock, meaning they didn't know what they were getting, versus this heavy compression sock 2 weeks after diagnosis of blood clot. and was followed them out for a year. Now I'm very familiar with the study because I was an investigator. So I enrolled patients in this study and we followed them. And it was sort of interesting because we measured them and they got them in the mail. So because I wasn't supposed to know when I did their assessment of post-thrombotic syndrome what they got. Well, I can tell you we sort of figured it out, but anyway. So that showed, unfortunately, that there was no difference in the prevention, not in the treatment, in the prevention by a clinical scale, as well as an ultrasound that we did to look for valve damage. People were very upset about those findings. They didn't believe it. And that's where the confusion of using compression for treatment versus prevention came from. The study was only to prevent. Now, what people criticized the study for was only about 67% of patients were compliant. So about a third of patients actually never worn them the way they were supposed to. And many felt part of that was the strength of it was quite high. We don't use the strength anymore. So there was a lot of worry and controversy, and people just didn't believe the trial. It was kind of this garbage in, garbage out. And I will tell you that's not. I mean, she designed it state of the art at the time. So fast forward, there have been now a number of studies, and some are even ongoing since that time, to redesign it, as well as you can see in the CHAPS trial, to use a lower strength sock where they believe the compliance would be better. And now to date, we have the Branges study as well as the Celeste trial that show, or sorry, the Ideal trial that show that actually there is a benefit. So you had 2 trials that said no benefit and 2 trials that did, and we have 2 that are ongoing. So there has been an update that just came out that was just published. You see here at the end of 2023 that looked at all of the studies. So here's the question: is it necessary, and for how long, to prevent post-thrombotic syndrome? And obviously you can't read this whole thing, but they looked at all of the studies that were randomized studies, 9 trials, and what they concluded is there in red, that indeed wearing elastic compression socks or stockings, ECS, can reduce the risk of developing post-thrombotic syndrome after DVT. And it was okay to wear them for a year. You didn't have to wear them out to 2 years, which had been the previous study. And their results support compression socks as a foundation. So there are still 2 trials ongoing, one with a less strength sock, and we'll talk about the strengths in a minute. But as of now, the guidelines are being updated based on this new analysis. And that, I think, for now, is the most updated word. Now, I can't tell you that there will not be another study with discordant results, but I do believe, based on the number of patients that they looked at and all of these trials combined, that they are deemed to be helpful. So hopefully, Todd, that answers your question, at least as of July 9th.
As of July 9th, yes, absolutely.
9th.
This is great information.
All right. So this as an overview for those who are really into compression. This is a document put out by the wound providers called the STRIDE document: shape, texture, refill, issues, dosage, and I have found, and full disclosure, I have nothing to do with this document, it to be the most comprehensive review of compression out there. And so someone who really wants to dig into this, I would recommend this publication that you can actually, find on your own. It really goes into the nitty-gritty of compression. So Leslie, let's go into how they come up with the strength, which I believe will address your question. Okay. So everybody think about their sweater, not here in July, maybe in Australia, they're wearing sweaters. So we have a body yarn, which you see, and then you have an inlay yarn that kind of gives the stretch to your sweater. And this is the same basis of how our compression garments are made. So you see, there's the most common is what's called the circular knit. Those are the ones you would buy the sweater at the store, or you'll buy the compression at the store. And then you have some that are fitted that tend to be what's called flat knit. And so you see on the right, the diagram, you have the inlay, the blue, which is provides the stretchy, the compression. And then you have you're sort of woven around it. And sometimes in the red, some of the more expensive garments will actually wrap each fiber in a cotton core, where you will have cotton only, or cotton outlay will be touching the body. And so for those that are, you know, sensitive, have sensitive skin, that's often something that you can look for. So here's the difference, because people don't understand this, but circular knit are, again, like your sweater, these are your ready-made compression. They're made on this, this machine. I actually had the opportunity to tour a plant from thread to final compression. It was really interesting. And it's graduated. There's no seam. What means is a high resting pressure when inactive, meaning when people are sitting, these are the most effective, or laying down. But these are very easy to put on and preferred for daytime use. That's in contrast to what's called the flat knit. This is a much thicker, denser, less stretchy. It's made on a machine there, where there's different needles that come in with different amounts of tension, and then they fold it over, and there's typically a seam. These are good for if you go in to get fit to a medical supply place. This is what you'll typically get, is a flat knit garment. And these tend to be a little bit less stretchy. So if somebody is walking or running, these will provide a little bit more compression, but maybe less comfortable, because they tend to be a little bit thicker. So for, you know, summer, it's a little bit hot. But if you went in to get custom, this is typically what you would be measured, and they would send off your measurements, and then you would get your compression back. So let's go over the millimeters of mercury. So the millimeters of mercury are the strength of compression. And this is actually at the top of our calf muscle is where it's standardized to, what's called the insert of the gastrocnemius muscle. And that's where everybody is standardized the compression to. Now, the problem comes about is many of the manufacturers of compression are European. The big three, Sigvaris, Juzo, Jobst, are all European countries, and they have a long history of making these. And in the US, obviously, we have a number of manufacturers now too. So I'm going to look at the US, and the way that these are classified is into these classes 1, 2, 3, and 4. And the millimeters of mercury is basically the tightness. So the higher the number, the tighter the socks. And so 15 to 20 are the ones that you'll see in the airport store. They're the travel socks typically. They're over the counter. You can get them at your local pharmacy. 20 to 30 are the ones that I typically use in my varicose vein patients, where now we're finding that these are more comfortable for patients. But you can get these over the counter, Amazon, all of that now also. You don't necessarily need a prescription. 30 to 40 are what we used to use. I will say that's, you know, at least in my circle of vein nerds, that very few people are using a 30 to 40, except if they have what's called lymphedema with it. And I'll talk about that in a minute. So those are the three classes, but you see there is some variability depending on what country you're in or what country makes the garment. So when you go to order something, if you look on the box, it may not line up with what the US compression classes, but you can see they're quite similar.
So before they order these, they should still have a talk with their doctor, right? The doctor should be recommending what strength for them to use, because otherwise it seems like someone's just guessing at what they need, right?
Yeah, and I think that's a follow-up question. We can talk about
Okay.
what to get and what the you know, and like I said, I'll go through how I approach it. And then, you know, full disclosure, like Leslie said, I've done this for a long time, but there's quite a bit of art to this in terms of what I've learned over the years of what's right for different people, their socioeconomic status, their lifestyle, their age. So let's talk about that a little bit. So here's some options to start. So you see on the left is a patient who's wrapped in an ACE bandage or a sports bandage. This is actually one of my patients who had a blood clot that came in with some swelling and has post-thrombotic syndrome. Now you say, why did you do that in the office? And I probably go through, 20 ACE bandages a day in my clinic. One of the things that's important to realize is that compression socks are maintenance. They are not treatment for swelling. You want to get the swelling out, And then you want to maintain it with your garment of choice. So this is why I start with this, is I tell my patients to wrap their legs, and I teach them, just like you see on the left, with just a plain old ace bandage for 2 or 3 days to wrap and wrap and wrap and wrap and get all that swelling up above the knee where the body can take care of it better. And then when they feel that their leg is as small as it's going to get, then go and obtain the compression. And I'll talk to you about how I feel. Again, full disclosure, this is my opinion. It may not be the same as who you see. So then you see one in the middle that has something a little bit more advanced. So this is what's called a triple layer wrap. Typically we use these for people that may need to stay in something for 2 or 3 days, someone who can't rewrap, or someone who may have a wound. It has a cotton liner, it has a compression bandage in the middle, and then it's held in place by this tape that's called Cobain. And then you see, I went to my CVS, and you see, here's an example of some ready-made compression socks, all the way from 10 to 15, 15 to 20, and 20 to 30. So I try to, you know, my kids won't go to the store with me because I do stuff like this. I'll take a picture of what's available in my local community. So this is what you might see. Typically, it's either in the sports section in the pharmacy, or in the pharmacy itself in the display, but not, you know, out there. So this is where you can typically find these. Of course, they're available online, Amazon, all sorts of places. So moving on to what should you pick? So here's that circular machine again. We have some examples of ready-made compression. You know, you're going to ask me, should you do the knee length? Should you do the thigh length? It's really patient preference and where you feel like your swelling is the worst. I feel like for most people, knee length are enough, but some people, especially depending on, you know, what they're wearing, prefer the thigh length. My experience with the thigh length is that they tend to fall down, especially on the bigger thighs, and, you know, full pantyhose may be a better option. But if there's just one leg that seems to be worse than the other, then the patient may, you know, want to wear a thigh length. So there's no right or wrong. The other thing that I say, especially in my older folks, because you say the word compression and they get a scowl on their face, is I think it's better to get that swelling out with the wrap and then start low. I had a 95-year-old woman in my clinic yesterday. Can you believe that? 95. Walked in with her walker. And she said, my arthritis, I can't get these socks on. And I'm like, well, you should wear the sock that you can wear. And so we actually started with an 8 to 10 compression sock in her. So that way they're less intimidated. And then as they get used to it, if they're, you know, then they can move to the next one or not. But some is better than none. Now, is an 8 to 10 or something lower going to prevent post-thrombotic? Maybe not. We don't have studies. We don't know. They're just starting to get those studies in the lower strengths. But I would rather them have some than none. And so I tend to tell people, start low, get used to them, and then move up. The other thing I tell them is, you don't have to wear them 10 hours the first day. Put them on for a few hours, get used to them, take them off. And if you get that indentation or that line, that means they're working. But remember, if you get the swelling out and you put them on in the morning, you will sometimes have that swelling by the end of the day because they're a maintenance, they're not a cure. But that's okay. You take them off, you get your feet up at night, and then you start over. And so this issue, oh, they cut in, well, that means we haven't started to get the swelling out before we, you know, get them on. But knowing that, yes, at the end of the day, you may be ready to be done with this. And that's okay.
When it comes to self-wrapping, so you're showing somebody how tightly to wrap, right?
Excellent question. Everything is about comfort. If it's not comfortable, people won't do it. So that's the other reason I like the wrap. You set me up perfectly, is because the patient now, you all have control. We need the control to be in the patient's hands. So if they get home and they say, ow, 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 she wrapped it too tight, this is what I tell them. You can rewrap it looser. Some compression is better than nothing. And then as they get the swelling out, they'll be able to wrap it a little bit firmer. But then there's relief because they know they can take it off.
Right.
They know they can wrap it, you know, that's looser. They have control. Whereas sometimes if you start with a tight sock and they don't like it, then you can never get them in it again. So again,
Right.
you're getting my personal bias, but that has seemed to work.
Yeah, but it's hard to stay compliant when you're uncomfortable and not having an easy time. It's really easy just to skip it.
Exactly. So I didn't give my 95-year-old patient, who I was thrilled to see walk in and out, a 20 to 30. I mean, there's just no way that in fact, she said it, someone gave her a 20 to 30 or even a 30 to 40, and she says, I can't get them on. So, all right, now, but there are some other options.
Before you move on,
Yes,
and you might get to this later, but for somebody who does the wrapping where you show them how to wrap, can they wear that all night long, or do you want that off before they go to sleep?
Yeah, so in our treatment phase, which may be anywhere from 24 hours to 2 or 3 days, I want them to wrap 24/7. I want them to do the good college try for 2 or 3 days and get as much swelling as they can out before we go to the maintenance phase, which is the sock. Now, I will say some people who have a lot of swelling at the end of the day that reaccumulates, and they get that big indentation, I have them wrap overnight if they tell me elevation overnight doesn't get the swelling out. If they need that little boost, and that may be very seasonal, it may be related to activity, it may be related to barbecue that day. In women, it can be cyclical based on menstrual cycle. So I will use that again as that go-to if they tell me overnight that swelling's not coming out.
Okay. And what about if the clot is in the arm versus the leg?
So it's another whole talk, but we now have a scale for post-thrombotic syndrome of the arm. It's a little bit of a different bird because arm clots tend to be in 2 groups, one which is called effort thrombosis or Paget-Schroeder, or those due to lines or port, for example, in a cancer chemotherapy patient. So there is a scale to rate it. There is compression and compression sleeves. There's a little bit nuance to that, Leslie, so I don't want to say too much about it. But
okay, that's fine.
Can use compression, and those garments are available.
Okay. Thank you.
So here are some other examples of compression. At the top, we have these pillow garments that instead of a wrap at night, people can put on overnight to mobilize fluid. On the right, we have a thigh-high, more of a flat knit. And then the other wraps that I really like are the Velcro-based wraps. On the left, we have the Faro basic wrap with 6 Velcro. And on the right, the Circade with 4 Velcro. These are options that can be worn day or night for people who have difficulty pulling or have arthritis in their hands, for people who want to be able to control the compression, for people with odd shaped legs, maybe thinner at the top and extra wide at, bottom or top. These are great options and have become available at quite a reasonable price. Like I said, even on Amazon or some of the compression sites. So I tend to use these a lot. Again, we're giving control back to the patient about what compression works for them. And now that these are so available at a reasonable price, I think they're great options. Remember, the theme here is some is better than none. There's no really,
That's right.
Right answer.
I don't want to get too far ahead, so just stop me if I am. But so when we're in the hospital and we have the leg pumpers on, right, the constricting, what's the difference between those and regular compression? And should people consider using those at home?
You
like
just saw my presentation, Todd. So here we go into compression pumps. So I want to finish with this, and then we'll talk about pumps. You really did your homework. You're like me. There's just some other ones that I like. You see this one. This actually just came out this year, and full disclosure, I've actually bought all the things that you see on this and worn at home before I give them to my patients. So that's how much of a nerd I am, because I don't like to use sort of off things until I know that they do it. Mm-hmm. So the one on the left, again, I have no financial with any of these companies. I'm just giving you examples. Okay. So I paid for these myself with my money. So the one on the left, I like, because if you have mostly ankle with, especially behind the ankle, what's called the gaiter area, you see the one on the left has these built-in silicone pads, which tends to put some compression in that area where you tend to get ulcers. So that's a nice option that patients can pull on. It's, I think, about $40. Some people talk about sleeves, you know, some of my guys want to go to the golf course, women too. They don't want to be a, you know, a dork with the long compression. As long as you have compression sleeve and wear a tennis shoe so you don't put the swelling into your foot, that's a great option. And then these ones, they're not, you know, the full thing, but there's a compression crew. I actually wore these to work today with my scrubs. And again, for summer, you can wear them with some gym shorts, at least in that highest risk area. From mid-calf down, you've got some compression. So, you know, all of these are options. Some is better than none. We understand there's different seasons, what people will do, but that lower leg area is the most important.
And just reiterate again why that is.
Because again, the blood's falling, causing the swelling, the inflammation, and ultimately those skin changes. That tends to happen where gravity has its biggest effect, which is at the ankle.
So are men more susceptible because of height, or is it pretty evenly distributed?
What a great question. So there is a study from my colleague, Nick Leeper at Stanford, looking at not in post-thrombotic, but the development of varicose veins related to height. And indeed there is. And I always tell my guys who watch NBA basketball that it's actually the reason Kevin Durant wears the full leggings. He wants to augment his venous return because he's so tall, and his venous pressure, of course, would be, you know, twice someone who's, you know, 5 foot tall. So it's a good question. All right, so just putting this all together, we have different garments that are listed on the top, and from the circular knit, which are the kind, like I told you, the sweater that you can buy at the store, to the ones that are Velcro based or even pillow based, and you can increase your compression strength that way, or you can do it by the actual garment being tighter. So the 15, the 20, the 20 to 30. So there's all, you can see all of the different options here that you can mix and match to see what's right for you. And there is no, excuse the pun, one size fits all. All right, so one other thing I want to get into is this issue of lymphedema, which has now sort of come up. So you see swelling and you see some skin changes. Well, it turns out the lymphatic system, people know about lymph nodes, is involved in clearing the fluid. And we've now learned that the lymphatic system clears most of the swelling. It brings it up to the lymph nodes where it's recycled. So this is now known as phlebo, meaning that came from vein disease, lymphedema. And most people who have swelling also have lymphedema. So this has provided an opportunity for another kind of therapy or additional therapy, which is called lymphedema physical therapy. And this is a series of maneuvers and therapy, including a massage, an exercise program designed to mobilize fluid, some bandaging similar to what I showed you, and then also some things with skin care. And, you know, in many cases, people who have not severe, but despite using standard compression, they need to do lymphedema therapy, which is the question I get, safe on blood thinners. You can do lymphedema therapy while you have chronic post-thrombotic and you're taking blood thinners. So one thing that came out this year that I think
What about how soon after your DVT or your blood clot can you start this physical therapy?
Well, typically you wait a few months to see, you know, you'll do all these things we talked about with wrapping and compression. And then if your swelling is unrelenting, that is when you would add, you know, so it wouldn't be, you know, day one is more of the wrapping and getting the swelling out. This is, you know, six months, a year in when you're still having problems and you need something additional. And speaking of which, just to put this in there, is that Medicare, you know, Congress did something. January 1st, the Medicare Lymphedema Treatment Act actually passed, which is now providing coverage for these garments, starting with all of them, the wraps, the 15 to 20, 20, 30, the Velcro, the pumps. So this is really a big deal for the Medicare patients who could get the therapy but had to buy their own garments. Now there is actually some coverage for this. This is huge. And that's why you can't get into a lymphedema therapist, because all our Medicare patients are sick. But just to let you know that if you have Medicare, there is some coverage, which is brand new. All right, we're in the home stretch. So what about these pumps? So there are pumps that are lymphedema pumps that are FDA approved. This gentleman on the right, some of you may recognize as LeBron James, he did a little piece on Good Morning America a few years ago for this Normatec sports recovery pump. That is not a lymphedema pump. In fact, it's in these high gyms, and it's a little bit of a pet peeve with mine because they've never been tested. And if you look up their FDA status, they're actually FDA harmful because they've not proven benefit versus the lymphedema pump. So I get this question a lot. The ones that you get on Amazon or sports, you know, for sports recovery, if you're a biker, that's fine, but they are not a substitute for the FDA approved lymphedema pumps. The risk is that you can damage lymphatics if too much pressure is applied for too long. So I wanted to answer that question because that comes up a lot.
Yeah.
All right. So the last slide here is just the C-TRACT trial. As many of you know, that one of the things is we don't want people to have post-thrombotic syndrome. And we want to know if by opening up a chronically occluded vein, so this is people who have the residual blockage in the vein, especially up high in the leg. Dr. Vendantham from Washington University has a $10 million NIH trial. He's in the home stretch, we hope, in this last year of recruitment, where people are randomized to getting the vein opened versus standard care using compression and other things we've talked about today, because we really want to find out if opening the vein is the right thing to do. The body is clever, and this is why you see such a difference. Some people with horrible blood clots have no swelling, and some people who have a relatively, minor blood clots have a lot of trouble. And so this study will hopefully answer the question of, now that we can open these closed veins, I'm on the steering committee, and I would encourage you, if you think you could be eligible, to go to the website. There's some questions there. There's centers all over the country. And so, like I said, we really want to get to the finish line with this study. Swelling, and some people who have a relatively, minor blood clots have a lot of trouble. And so this study will hopefully answer the question of, now that we can open these closed veins, I'm on the steering committee, and I would encourage you, if you think you could be eligible, to go to the website. There's some questions there. There's centers all over the country. And so, like I said, we really want to get to the finish line with this study. So with that, that is the end of my presentation, but I would be happy to take some questions.
Yes, and we have a ton of them. And before we get to the questions, I want to pass something along to you and get your opinion. So I was on a flight on Sunday night. I'm wearing my Stop the Clot acronym for everybody to see while I'm on the airplane. And I was talking to the flight attendant, and she said, "Oh, I'm wearing compression socks so I don't get a blood clot." And I said, well, I don't know if actually compression prevents you from getting a blood clot, but it can help with many other things. So what is the response to that? Does compression actually prevent, or is it real?
Yeah. So the thing about this is, Leslie, is that there's not a study that have randomized people who flew. There actually is a study that randomized people, that they looked at people in a movie theater and they looked at people on a plane and who got compression. It was about flights. So what current guidelines are if you have a history of a blood clot, then wearing compression socks on long haul travel over 4 hours, whether in the car or on a plane, is recommended. Is there a randomized study to support? No, but that is the recommendation. So even if you've had a history, you're now off blood thinners. Like I have a lot of patients who had knee replacements, they get treated, now they're off. That is the current guideline. There is not a study that says if you're Joe Blow and never have a history, no risk factors, that wearing them will prevent a blood clot. Now, it seems intuitive, but there is not a study that proves it.
And so for those folks that have had a blood clot previously, and you recommend them using the compression socks 4 hours, etc., plane, train, automobile. Does it matter which grade they get? Is everything fair game from wrapping your own leg to the highest
Yeah, so again, this is clinical, my opinion. There's not good studies on it. Like I said, if you go to the Hudson News in the airport and look at the socks that say travel socks, most of them are a 15 to 20. So that's the most common recommendation. But I would say some is better than none, but I can't tell you 20 to 30 is better than 15 to 20. It may be, but there's no study.
Okay. It's really frustrating because, you know, like I'll use myself as the example. I had 2 different doctors that gave 2 different opinions. One said use compression and one said don't bother. But personally, I can say that your legs feel a lot better and I have less swelling when I do use compression on the occasion. So,
But
But again, one is prevent. See, if everybody got confused after the SOX trial, that was only for prevention.
yeah,
Current guidelines recommend compression socks to treat the swelling that you may have.
right.
And there is no controversy about that.
Right. And at the NBCA, we preach all the time, and we have standards when it comes to travel. No matter what type of transportation it is, I mean, whether it's movement, hydration, there's so many things you can do for the prevention of blood clots. And that's what's lacking, is that information of people getting on the flights. A lot of them have never heard about this. So they'll sit for 6 or 7 hours and not do any of the things they're supposed to. And then we have problems. But thank you for the presentation, because, you know, Leslie, it's funny, we have these pep talks all the time, and it always seems like I'm loading up a whole legal pad here of notes. But
I know things we learn.
You answered a ton of questions that we've been looking for answers for, and I think it's going to help out patients. Real quickly, I just want to tell you before we get into all the patient questions is I had my 7th blood clot just a couple of months ago. I'm not going to go into why and all that stuff, but this was the first time that I ever used compression after a blood clot because, and maybe I don't like the word luck, but maybe I got lucky, and none of the previous DVTs ever gave me much pain and swelling. This last one did. And so for the very first time, my doctor said, now you can wear compression. Now this is when you wear compression. And I think it was just 10 to 15 gauge. It was just a calf sleeve. But the night of my diagnosis, I put that thing on, and I swear to God, the next day my swelling was gone. I took it off later that night, but my swelling was gone, my pain was gone, and for some odd reason, the swelling never returned. So it was like we prevented that from developing, kind of like what you were talking about. But I just never used compression, and now that I do, I praise it because I can speak from experience that it does help with pain and swelling. I want to focus just a little bit real quick on the patients again, if they're thinking about compression and the questions that they should be asking their doctors, because people ask this all the time. If they're pregnant, if they've been hospitalized, if they have May Thurner, all kinds of people are out there asking these questions, but they're not exactly sure how to present those questions or what questions. If a patient has pain and swelling after a DVT, it just starts up and they go to the doctor, what specific questions should they be asking, or what should they be asking for?
Well, I think you set up the scenario. I think the first thing to define is if it's a patient with a new clot, are we preventing? Sometimes we're preventing and treating at the same time, right? What is the goal of compression? Prevent or treat. So when you go into your physician, you want to say, these are the symptoms and signs I'm having, or I have none, but I'm worried I'm going to get them. So that's step 1. Okay. And then the second thing is, you have to tell them a little bit about what you do, what your goals are, what your activity level is, and then I think that will help your provider decide what's best for you. So I think, what should they ask them? I think that's first, is what are the goals? This is, what I'm looking for. These are the symptoms. And then, what are the different options, which, I've given you an array tonight, about this, but unfortunately, there's no one specialty that does this. I think vascular medicine in general, my specialty, probably has the best understanding. And then those who are, I'm also a member of the American Venous and Lymphatic Society, so they also probably have the best understanding of this. But unfortunately, you will get that controversy about some doctors will still tell you don't do them.
Mm-hmm. Yeah, as a doctor, you've seen so much, you've heard so much, but one thing I've realized in dealing with all the patients is there's very few carbon copy stories. Everybody's so different. The level of swelling, level of pain, the reasons, all that is so different that it can be really confusing for the patients because they'll talk amongst each other and they're not relating because it's so different. But hopefully they get that guidance from the doctor. And I think doctors are doing a much better job today talking about blood clots, where back when my mom died in 1984 from a PE, no one talked about blood clots. But we got to keep doing that. And I really appreciate your work. So thank you.
All right, let's get to the questions, because we have a lot of them and people have been waiting to ask. So I'm going to jump in first. I think this is a great question. What is the difference between post-thrombotic syndrome and chronic venous insufficiency? I have been diagnosed with both and I don't understand the difference.
Yeah, so in someone who has a blood clot, who has post-thrombotic syndrome, that and chronic venous insufficiency are the same. They're the same signs and symptoms, okay? In someone who's never had a blood clot, some people who have bad varicose veins, often genetic, due to weight, due to other things, can develop chronic venous insufficiency where the valves of the veins, either deep or surface, leak and cause similar skin findings, but they've never had a blood clot. So post-thrombotic syndrome is a subset of chronic venous insufficiency.
Okay, great answer. Thank you. Todd?
Somebody asking about zipper compression. I didn't even know they had that. So
I didn't either.
What do you think about zipper compression? Are those just as effective?
Yeah, so again, zipper compression, this is patient preference. Mm-hmm. There are some people who prefer to get them on with the zipper. It's easier for them and they don't mind the seam. So again, I will say, whatever compression you prefer, wear that. Personally, I don't like the seam touching my skin where you pull the zipper up. So it's not for me, but zipper compression is fine. There's no downside.
Okay. Leslie?
Okay. I've been wearing 20 to 30 milligram compression socks for about 7 months now, almost every day until late afternoon. I seem to have a permanent indentation right under my knee where the top of the sock is. Is this a problem?
Yeah, and I think we talked about that a little bit earlier, but what I would say is maybe spend a couple of days doing the wrapping and getting the swelling out, and then get your sock on. But just like I said, at the end, these are not a treatment. These are a management. And at the end of the day, especially if you sit or stand long hours, you are going to have that indentation. If it goes down overnight, you don't have to wear anything at night. But if it doesn't, then you may want to do a wrapping overnight to get rid of that residual swelling. But it's not unusual. By the end of the day, you're ready to rip them off, and that's okay.
Okay.
Are there any natural fiber compression socks available?
I'm sure there are. I guess there's so many different vendors now that I would say, I used to say in general, you get what you pay for, but I've had lots of people that have gone online that have gotten really great compression socks for $10. So I'm not familiar, Todd. I will say the European brands that are sort of the long-standing ones, they do tend to have the cotton, wrap on them where you don't have the fiber on your skin. So there's less irritation and latex allergy.
Sure. Okay. Thank you. Leslie?
So I'm going to read a comment and then I'm going to pose a question from somebody else, because I think this comment is actually really interesting. So this is a tip for those who struggle with compression garments, because you know what? They are hard sometimes to put on, depending upon what grade they are. Sigvaris brand Magnite on and off as a sock don or doffer. So easy, made of parachute fabric and uses magnets to allow the garment to slide onto the leg. What a great thing. I didn't even know that existed. Don't know what the cost of it is, but I mean, certainly to help get those socks on. And then the question, how long can you wear and wash a compression socks until you need to replace it?
Yeah,
Good
so
question.
in general, if you wear one pair every day, it's 3 months. If you have one pair for each day of the week, typically we tell you to replace them once a year.
Okay.
And so we talked about this is the first time I've used compression, so I'm not used to going out and shopping for compression. I don't know how the prices, I don't know what that price window looks like, but a lot of people ask, does insurance cover any of those compression needs?
Yeah, so the Medicare, what I told you, if you use the word lymphedema with it, you can get it. But in general, it's very hit or miss. For example, there are some Blue Cross Blue Shield plans that will cover some. The VA system covers them. TRICARE, which is associated with the military, tends to cover some. Some of the federal insurance plans tend to cover some, but you have to essentially check with your insurance plan.
Okay.
There's some great questions here. For
Mhm.
endurance athletes with a history of DVT, is it best to wear compression socks before, after, and or during exercise?
This is funny. So if you look at the Boston Marathon winners from 20 years ago to more recent, 20 years ago, there was no compression, and now you'll see many of the top runners wear them. Why is that? Well, it's this theory of venous return. If you are running and demanding a lot of blood to your muscles through your arteries, all that blood has to get back to your veins. And that's where the sports thing has come in. And so now you see a lot of your athletes wearing them. They're trying to augment that venous return so that they don't have achy legs during their thing. So that's one perspective, with or without a blood clot. The other perspective is when you're using your calf pump, especially if you're doing a running motion, that is sort of, your natural pump to get the swelling and that out. And sometimes compression may make no difference. So people say, do I have to exercise with them? And I'm like, if it feels better, do it. If it doesn't, don't.
So to kind of piggyback off that, what about the endurance athletes? And so I'm just curious about compression again. Is there such thing as waterproof compression? Can compression get wet? Can people that are active and have to work on water, do they have to have a special kind of compression?
Yeah, again, that's a great question. Shoot, I should go and invent that, right? Go and market it.
There you go.
No, I'm not aware if there's any waterproof compression out there. So if somebody in the audience knows, feel free to put it in the chat.
I'm thinking we may have some triathlon folks out there. We have a lot of them.
Yeah, that's right. And maybe a triathlon
Mhm.
coming up in the not too distant future.
Yeah.
Okay.
I mean,
Okay.
a wetsuit has compression, right? So
That's right.
it may be built into that. So
That's a good point. I wear a full body wetsuit and you get different strengths of that too, 2 millimeter, 3 millimeter. Yeah, good point.
I've purchased compression socks on Amazon, not totally knowing very much about compression. I have factor 5 and have had superficial clotting in my arm and legs. Is there a medically approved brand that is recommended?
yeah, I used to say, about 10 years ago, there were 3 big European brands, Juzo, Jobs, Sigvaris. There's also Medi. Those are your big 4 that have done this a long time. I would say those are the most reputable, but also the most expensive. They have the best selection though, in terms of medical grade. But again, I've every patient I see has these, and I've seen many that people got online at different vendors that are great. So, I can't really say one brand is now better than another anymore.
Is there any benefit to maybe while you don't have compression on, just elevating your leg? Would that bring
Oh yeah, but just remember, elevation's only half of it. You have to use your pump. So I tell people, just make sure that walking motion is really important.
Right.
Elevation is not enough. You have to pump. Back to your compression question. I was thinking of something. I usually do a sock, but if you put your hand in a sock and you stretch it, if you can see the elastic white fibers too easily, it's probably not a good quality sock. If you have to put a little give in there, then it's probably better quality. That's one little trick that you can use.
Okay.
Leslie?
I think what we're going to do is two more questions and then we'll go to the polls, and because I want to be mindful of everybody's time this evening, but I do want to put you on the spot. It would be wonderful if we could create with your assistance a compression guide and commonly asked questions that we could have available to patients, given that this is such an important topic for them post their blood clot experience. So my final question is going to be, my doctor said since I'm on blood thinners, I don't need to wear compression socks. But what about traveling, particularly long distance?
Okay, so I think the question is, go back to that we talked about the interaction with your provider, is what is your goal? If your goal is to treat swelling when you're sitting traveling, then that will be controlled with some compression. If your goal is to prevent a blood clot and you're already on blood thinner, they're right, you don't need it, you're on a blood thinner. So I think it depends on your goal.
Okay.
But knowing that you may have, if you sit long hours and you may have some swelling at the end of your trip. So you need to define what the goal is. But in general, if you're on blood thinners, nothing is 100%. But if you're on blood thinners, then yes, you're protected from travel-related blood clots.
Okay. Mr. Robertson?
Well, and actually, and I don't have just another question off the top of my head, but I want to answer somebody. We had a couple of people ask if this is going to be recorded and replayed because they got in a little late from work. And I just want to assure everybody that this pep talk and all the other pep talks are in our media library, which you can watch. So yes, it will be recorded and it'll be up in a couple of days live, and I'll make sure that it gets up in the group. And then of course, we'll push it out on our website as well.
And I want to reiterate, I mean, a lot of what I've talked to you today is personal experience, that disclosure, this does not represent the opinion of whatever that you see. Obviously, I have many skilled colleagues, and we all share our own experiences on blogs and things that I'm on, and I learned from them. So, my word isn't the last word, and I would, it's great that you all are on this, and I would encourage you to continue, seeking information.
I learned so much from you, as does everybody, every time we speak to you about compression. This is so fabulous, everything that you share with us. Okay, Todd, why don't you kick off the final polling questions at the end?
Sure. We'll go ahead and read these questions off when they pop up. I'll have you guys just quickly answer those, and then we're going to go ahead and give the results. Sure, appreciate everybody being here tonight. Are you interested in receiving more information about compression from the NBCA? Yes or no? And just one other question. Do you feel more qualified to discuss compression with your doctor post tonight's event? Yes, no, not applicable. You can answer those real quick. We'll go ahead and give you the results. We'll let you get on with your evening. I learned a ton, love pep talks, love all the information that we gather. Okay, should be popping up here, and here we go. Are you interested in receiving more information about compression from the NBCA? 94% said yes. Do you feel more qualified to discuss compression with your doctor post tonight's event? 82% said yes. That's an excellent number. 5% said no. Hopefully you'll be able to go back and rewatch this and put together some questions and get some more confidence and go in and talk to your doctor. I think it's really important. But thank you for answering the poll questions. Leslie, I'm going to let you say goodbye to everybody.
Well, Dr. Wasan, thank you again. We'll see you next year, same time, same place.
Yes.
For third annual. And definitely we're going to get this guide up and out to people so that we can answer everyone's questions on compression. Thank you again for all of your assistance and help tonight.
Yes, thank you.
Thank you.
Good night, everybody.
Good night.